Next talk is going to be from Professor Khean Lee. I believe that many of you is going to know Professor Goh very well. He is leadership in many positions of the GI Society in Asian Pacific region, such as past president of the Asian Pacific Association of Gastroenterologists and past vice president of the WGO. Today, Professor Goh can let us know more about how to treat the GERD patients in these important regions. Please.
Mr. Chairman, ladies and gentlemen, the title of my lecture is Key Findings of the Southeast Asian Consensus on Mild to Moderate GERD. From the outset, I wish to declare that this consensus process and consensus meeting was funded or supported by Reckitt Healthcare, and therefore I shall be touching upon the acid pocket and the alginates in my lecture. The consensus statement is now published in the Journal of Gastroenterology and Hepatology Open. What is this consensus and how was it developed? The objective of the consensus is to develop agreement on a set of statements to guide the practical approach to the diagnosis and management of mild to moderate GERD in Southeast Asia region. And it consists of a steering committee, of which I was the coordinator and convener, together with Professor Somchai, Professor Lee, and Dr. Ruben Wong. And we had 6 other members of the expert panel from 5 other Southeast Asian countries, Professor Dadang Kwok, Solano, Montira, Ajay Fendi, and Professor Tran. The consensus process, the statements were drawn up by the convener and the steering committee, and voting was made based on the modified Delphi method. After the first round voting, there was discussion and modification of statements. In second round, final voting. Great evidence and recommendations were made based on a grade system. Agreement ranged from strongly agree minor reservations, to strongly disagree, and a consensus level of 80% or more strongly agree and agree with minor reservations is considered reaching a consensus level of consensus agreement. All right, let me first start by talking about diagnosis of GERD. Diagnosis of GERD is based firstly on symptoms of reflux, cardinal symptoms of reflux. Secondly, on erosive esophagitis and gastroscopy. And thirdly, on pH measurements. The classical symptoms of GERD are heartburn and acid regurgitation. In Asian Pacific region, many patients complain of substernal chest pain and food regurgitation, and these 2 symptoms are also considered major symptoms or cardinal symptoms of GERD. The diagnosis of mild to moderate GERD is made based on symptoms and is defined as awareness of reflux symptoms not easily tolerated and or discomforting reflux symptoms sufficient to cause interference with normal activities but is tolerable. The majority of cases in the Southeast Asian region are non-erosive reflux disease, mainly mild grades of reflux, or if they have reflux esophagitis, mainly mild grades, as low prevalence of complication, including Barrett's esophagus. In short, in the majority of patients in Southeast Asia, GERD is a mild to moderate disease. Presentation reflux symptoms in practice. Symptoms of GERD are very, very common in clinic. Symptoms are subjective, and there's so much hype about GERD or acid reflux amongst our patients. Now, almost every upper GI symptom is nowadays considered as a reflux symptom. Patients make a self-diagnosis, and when you see them in the clinic, you ask them specifically what their symptoms are. They'll tell you it's belching and burping. They consider that or sore throat, windless chest discomfort. Reflux symptoms are therefore a very, very mixed bag and often do not indicate genuine GERD and have a poor response to acid therapy. Let us look at this chart to understand certain concepts about NERD, reflux hypersensitivity, and functional heartburn. When you have patients with endoscopy normal and on pH measurement, acid reflux is present, then these patients have GERD, or what is known as non-erosive reflux disease. If acid reflux is absent and symptom association probability is positive, patients have reflux hypersensitivity. On the other hand, if a patient's SAP is negative, the patient has functional heartburn. If patient has acid reflux absent, but impedance is positive, these patients may have weakly acidic or alkaline reflux, and these are patients with reflux hypersensitivity. If the impedance is negative, patients then have functional heartburn. So you have here in a spectrum, and this is proposed by Kasim-Aziz and colleagues, now following their own tree in discussions, that on the left-hand side of the spectrum, where acid exposure is maximum, patients have erosive esophagitis. On the other hand, if a patient has no acid exposure or very little acid exposure, is on the right-hand side of the spectrum, and these patients have reflux hypersensitivity and functional heartburn. So when you deal with GERD symptoms in clinical practice, you're dealing with no patients with true GERD, but you have a lot of patients with functional heartburn or reflux hypersensitivity as well, or non-GERD symptoms. Sometimes they are non-GERD symptoms in the first place. Therefore, it is understandable that there is suboptimal response to the inhibitors. So statement 5, many cases of non-erosive reflux disease have poor response to PPIs or breakthrough symptoms or on PPI treatment. In this study that was published several years ago, which is entitled Unmet Treatment Needs of Gastroesophageal Reflux Disease in Asia, we had a group of patients who were physician-diagnosed GERD, and we looked at their response to PPI. These patients, majority of them, more than 2/3 of them, have partial or no response to PPI. On top of this, 62% have experienced breakthrough symptoms at night, and 23% of these patients will have a good night's sleep. Furthermore, of all the patients, almost half of them have to use additional treatments to manage their gastroesophageal reflux symptoms. In another study, this is an earlier study carried out by the American Gastroenterological Association, again, a large majority of patients were somewhat dissatisfied, completely dissatisfied with PPI treatment for their GERD. Again, 38% had breakthrough symptoms, even though they were taking PPIs, and 56% of patients had to take or use additional medications to manage their breakthrough symptoms. Statement 6. The acid pocket is a physiological finding in the human stomach formed after a meal. The idea of acid pocket was first proposed by Ken McCall from Glasgow in 2001, where he described accumulation of a highly acidic layer in the cardia of the stomach after a meal. This is very well seen in this chart here. This patient is fasting, patient who had eaten food, and after eating food, the food buffers the pH in the human stomach, and is alkaline, and the pH is pH is alkaline, and about the same level as in the lower esophagus. However, at the CO junction area, there's an area of highly acidic contents, and this is called acid pocket. So Ken McCall and colleagues described it as a unique intragastric region which becomes highly acidic following a meal. And they further stated that this acidification of cardia is a source of postprandial acid reflux. You can see this very well in this high definition surface contour plot. So this patient is fasting. At 17 minutes after eating, you can find that an acid layer has already formed near the slow junction. At 43.5 minutes and 47.5 minutes, this layer thickens, and at 47.5 minutes, you can actually see the acid flux taking place. Statement 7, the acid pocket plays an important role in causing acid reflux. Let me say a few things about the acid pocket and gastroesophageal reflux disease. Differences have been observed in the size and distribution of the acid pocket in GERD versus health. In GERD patients, the pocket is longer. The pocket extends, in fact, closer to or across the gastroesophageal junction. The position of the pocket is altered hiatus hernia. It is located in a hiatus sac above the diaphragm when there's a hiatus hernia, and you can understand why migration of acid films or the acid pocket or acid film onto the distal esophageal mucosa takes place easily, and this contributes to a high prevalence of mucosal disease in a region. Furthermore, it has been observed that hiatus hernia can occur transiently and occurs very frequently in patients with reflux disease. Transient hiatus hernia causes intermittent separation of the lower sphincter and diaphragm and pulls the acid pocket above the diaphragm. The upward movement of the acid pocket, as you can see here, with hiatus hernia increases the risk of acid reflux. Statement 8, alginate compounds form a trough above the acid pocket and prevents reflux of acid and non-acidic contents, volume reflux, of the stomach to the lower esophagus. So if you look at tackling or treating the acid pocket, you take alginates, it forms a physical barrier above the acid pocket in green here and above the fold in red here. What are alginates? Alginates are anionic polysaccharide distributed widely in the cell walls of brown algae. It has special characteristics. This alginate, it binds with water and forms a viscous gum and absorbs water quickly, capable of absorbing 200 to 300 times its own weight in water. So what happens when the alginates are taken? It interacts with hydrochloric acid, forming alginic acid. And then the sodium bicarbonate in the alginate compound interacts with hydrochloric acid, forming CO2. So the CO2 and the alginic acid forms the alginate raft. The alginate raft displaces the acid pocket, traps pepsin and bile, and impedes the reflux of gastric contents. And its efficacy is well shown in this study here. This is patients who measured the lower esophageal pH, first hour, second hour, third hour, fourth hour after ingestion. You can see in the first hour the amount of protection against acid is equivalent to PPI, and even at the second hour, alginates is almost comparable to PPI as well. Treatment is targeted at symptoms. The features of first-line treatment for GERD is that it has to have a quick and effective relief of symptoms that can be used repeatedly and safely and easily available. So statement 15, alginates should be considered for empirical treatment for patients with mild to moderate symptoms of acid reflux disease. If you look at this meta-analysis, which compares alginates versus placebo antacid, you can see that alginates are superior, and when you compare alginates versus PPI H2RA, it is also comparable, even though numerically most studies show superiority with PPIs or H2 antagonists. Statement 16. PPIs are the mainstay of treatment for patients with persistent symptoms of GERD. And our consensus statement ends up with the algorithm in the management of GERD clinical practice. We propose or we recommend that in patients with mild to moderate GERD, lifestyle measures should be introduced first. This includes avoiding late evening meals, reducing alcohol intake and smoking, sleeping in a head elevated position. If patients have symptoms, then they're given alginates. PPIs if the symptoms persist. And combination therapy of alginates and PPIs is partially responsible to PPIs. And the improvement in symptoms long-term, patients are recommended to take alginates or PPIs on a PRN basis or on a maintenance dose.
Thank you so much, Professor Goh, for your excellent talks.